Welcome again to another edition of our Focus on Facebook Live. I'm Dr. Hasnain Kermali, Chief Medical Officer here at St. Mary's Hospital in Waterbury, Connecticut. Each month we highlight one of our clinical departments and bring to bear the different services and experiences and clinical expertise that we'd like to offer and we have available for our patients here in the Waterbury community. Today I'm really excited and happy to welcome our new endocrine surgeon, Dr. Grace Lee. Welcome.
Thank you so much for having me today.
And thank you so much for joining us. So Dr. Lee is fairly new to St. Mary's and Trinity Health of New England. Came on board just last fall, so not too long. Really excited to have you here and what you're able to offer our patients in the greater Waterbury area. So as we've done before, short period of time, but I want to first talk about who you are, new to St. Mary's. So let's talk about a little bit of background of yourself.
Okay, well, Dr. Kermali, once again, thank you so much for inviting me and giving me this opportunity to just say hello to all the folks out there in the community. As we were just briefly chit-chatting about, I think I'll get to know the patient well from the clinical side, but I don't think we give our patients enough time to get to know me as a person, not just as a clinician. So, I think this is a great opportunity. I hail from the Midwest. I'm not from up here, but through various trainings and schools, I found myself up here. I spent some time in Boston area, and also brother of mine decided to establish family up here and have some kids. So that's what drew me to Connecticut and Northeast.
Wonderful. Well, we like to say we're a big family as well. So welcome to our family too. I think that's what made St. Mary's welcoming for me as well, was just how quickly we recognized we become brothers and sisters here very quickly amongst our staff and our patients. And I think that's what brings us back to work every day. It's that love of the environment that keeps us going.
Absolutely, for sure. I mean, I've been very impressed by different expertise that are represented at St. Mary's, and just top-notch departments here. But then at the same time, everybody's so collegial and willing to help, and they're friendly. So it's been a very easy transition.
Great.
I've been in practice for 8 years, and I've practiced at various different parts of the states, and this has been a great setup for me to establish endocrine surgery.
Wonderful. And I'm glad you've been having a very positive experience. So let's talk about endocrine surgery, very specific subspecialty of general surgery. Tell us a little bit about endocrine surgery itself.
Yes. So I am actually board certified in general surgery. So I've done my shares of bread and butter general surgical procedures. And then I decided to pursue specifically the subspecialty of endocrine surgery. So I now just remove thyroid, parathyroids, and adrenal glands. I focus all my practice on those 3 specific glands. And not only I just remove them, I also treat them and diagnose them with various different techniques. So I also treat benign diseases as well as cancer or malignant diseases of thyroid as well as adrenal glands.
Sure. So when we think about thyroid and adrenal glands, thyroid to me is the simpler one to remember, because whenever we go to a doctor, they'll like swallow and check the thyroid. But the last time I checked, we don't really do a good job of a physical exam on the adrenal gland.
Yes.
So where's the adrenal gland? How do you get to the adrenal glands?
That's a very excellent question. So adrenal glands tend to have nodules just like thyroids and parathyroids, and those are incidentally found most of the times. If you happen to come in with abdominal pain to the emergency department and get a CT scan, or if you happen to have back pain and get a CT scan, sometimes we just find these little thistles of nodules
Sure.
in the adrenal gland. And by and large, they're small enough and they're just there, not secreting anything, so we don't really have to do much investigation. But there are those adrenal nodules that are secreting extra hormones. So that's where we come in to investigate to see if this needs to be intervened, meaning if it needs to be taken out. So luckily there are not that many adrenal pathologies out there, but if we happen to pick up on incidental adrenal nodules, then we do further investigation, and sometimes we unearth some of the underlying pathologies that were driving up the blood pressure issues or sugar issues. So it can be a very rewarding journey with the patient. You know, sometimes they're surprised by the finding of adrenal incidentoloma that they weren't expecting. But if everything goes well, I mean, it can be life-changing for some.
Yeah. And in fact, I remember there was a case of an adult patient who was having some difficulties with behavior, and sugars kept dropping low.
Okay.
And because he had a developmental disability, it was really hard to get a good diagnosis or a good history from him in terms of tell us what you're doing. And then did a CAT scan ultimately because of some of the concerns we had, and lo and behold, there was something growing there. And then soon, within a couple of days, it didn't take long for us to figure out, hey, we've got an issue here about a hormone secreting or releasing problem in one of these glands that needed to come out, and then he was taken care of and fixed. Nice. which is remarkable. So I can appreciate where you're coming from because I've seen it and how beneficial it's been.
Absolutely.
But when we talk about surgery, we worry about like large scars and large recovery.
Yes.
But you're focused on minimally invasive management of these. Can you tell us a little bit more about that?
Absolutely. So coming from general surgery background, I'm very well versed in laparoscopic procedures and robot-assisted procedures for adrenalectomies.
Great.
And so for the most part, patients will get to go home the next day.
Beautiful.
And will be able to avoid a really large, painful incision for that sort of a surgery. And the beauty of adrenal gland surgery is getting the patient prepared. So for instance, if they happen to have a pathology like pheochromocytoma, it really takes the surgeon and the endocrinologist and primary care physician and the patient to be on the same team about making sure the patient is ready and safe to undergo the surgery together. So as long as the patient is appropriately, what we say, prepared for the surgery is probably the easiest part.
Right, yeah.
And the recovery after these laparoscopic or small keyhole incision surgeries are, not as involved as older time, longer incision surgeries. So we usually are able to send them back to work in a couple of weeks.
And that's remarkable. So that's adrenals. What about thyroid? So now we're talking about neck surgery and removal of thyroid. Can you tell us, I guess, and maybe we'll get to it. What about minimally invasive for thyroid?
Yes. So we try to make as small of a possible incisions for thyroid surgery as well as parathyroid gland surgery. And minimally invasive has a different meaning up here in the neck, and now we are adding more techniques to make that incision smaller and smaller. In some centers, we're doing even scar-less operations, and because of that drive to eliminate potentially unsightly incision, we are now doing more needle-driven, what we call percutaneous approach to addressing some of these thyroid nodule and very small thyroid cancer situations. So the field is forever evolving, and it's getting better each day. And I think patients and folks out there who are wondering about what to consider for their own treatment of thyroid nodule issues or parathyroid issues, I think it's good to have opinion of different experts and people who do this day in and day out, so they're well educated on the treatment options. And that's one of the things that I really enjoy the most, letting the patients know this is available for you and this is why we are actually recommending this procedure, or this is why we're not recommending certain procedures. I think it's very important to let patients know that there is the right time to do certain things and there are right times not to do certain things. So that's what I really enjoy the most about this field.
And you mentioned even beforehand the collaboration
Absolutely.
that you do with the multiple specialties that are involved, from the primary care doctor to sometimes the endocrine doctor, their thyroid doctor, or their adrenal doctor, and then working with you as well. So there's a complete team that wraps around the patient.
Absolutely.
Keeping the patient at the center of it, which is what we strive to do here at St. Mary's.
Yes, yeah, absolutely. As you mentioned earlier, it's a big family here, and it really takes a village to not just raise a child, but take care of a patient.
Yeah.
Along with their family support and all the specialties and their expertise, and we have all the right pieces in place at St. Mary's, thanks to the leadership and people who are really trying to bring the best care possible to the patients, so patients don't have to travel elsewhere and seek those care, but we are actually bringing all those things to the patients.
Well, the focus has been to be able to continue to provide care in their backyard.
Absolutely.
And so this is the reason why we focused in. I mean, we've got a great endocrine service here, and the one thing that they kept telling us was, and this I think is the beauty here, is that it's the physicians who are helping sort of the leadership, so to speak, but it's physicians who are guiding St. Mary's in where we need to help the patients. And so we take a very collaborative approach. So when the endocrine physicians are saying, hey, we need an endocrine surgeon because we're seeing a lot of thyroids or adrenal issues, and how can we support these patients? It was very quick for our understanding to say, hey, we need to get this going here.
Yeah, thank you for listening to them.
Well, I mean, it's important. We always say we have to listen to the patient, and the physicians are part of that. It's what the patients want as well. So I'm glad we were able to get there. So let's talk about some of the other specialists that you do work with. When we think about thyroid or even parathyroid, that small little nodule that's sitting inside the thyroid, who are some of the other doctors that you work with?
Yes, so I work very closely with the radiologists here. We have different techniques of locating those itty-bitty tiny parathyroid glands. So we have excellent ultrasonographers and ultrasound radiologists, as well as nuclear medicine radiologists, and for the CTs. So we use a very specific protocol for parathyroid CT called 4-dimensional dynamic CTs.
Beautiful.
Yes, and that way, as we started talking about earlier, we don't have to go searching for the parathyroid gland. The more specific and accurate mapping of the parathyroid we have ahead of the time, we can minimize the surgery time and incision as well, and make the surgery as easy and painless for the patient.
Beautiful, beautiful. So that's the radiologist. What about, how does a patient know that they've got a problem with their parathyroid? I mean, it's not something that shows up in your, on your day-to-day work, or does it? Or do they start to see things that they're like, this is odd. Maybe I should check my parathyroid.
So by and large, I think the most common symptoms that patients tend to have are having a history of kidney stones and record of high calcium on their routine workup. And sometimes because the patient has bone density loss, such as osteopenia or osteoporosis, their primary care physicians will engage them in further workup, and then we get to parathyroid issues that are a little bit less common as well. It's just biochemical values are not always high calcium, high parathyroid hormones. Sometimes it can be shades of gray and a little bit difficult to diagnose. So that's one of the reasons that we work closely with experts in endocrinology and as well as primary care physicians who know the patient and are very acutely aware of what's going on with the patient. If the patient starts to complain about tiredness, forgetfulness, and just various symptoms that are related to parathyroid disease, then those are the folks at the forefront who will eventually diagnose and bring those patients to me for treatment.
Yeah.
So I think that's one of the ways that patients can get on the pathway of getting diagnosed with the parathyroid issues.
Well, you mentioned it's fortuitous that you mentioned the kidney stone, because we're actually launching a kidney stone program here as well with our urologists. So,
excellent.
All of these pathways are to try to combine, and the beauty about our bodies, I think, is that many of the systems are interconnected.
Absolutely.
And so by having a team approach that, hey, we've got a kidney stone program, and if we're starting to see more patients with these high stones, high calcium stones, and then we start to deliver them to the endocrine doctor to say, hey, what's going on with it? Why is their calcium so high? Or why are they getting early bone disease?
Yes.
And this is how we're going to interconnect it for the patient. Again, trying to simplify, but sometimes it's a relatively complex disease.
Absolutely. I mean, we have excellent urologists here, Dr. Kim and Dr. Moy.
Yes.
And they're very well versed in treating kidney stones once that happen. But then my job and the endocrinologists and primary care physicians here, we are trying to prevent those kidney stones from happening again and again. So yes, it's really important to work in collaboration with the various departments and get to the bottom of the condition.
Yeah. And then whenever I think about surgery and taking something away from the body, the question that goes on my mind is, well, is the body going to miss that? and then how are we going to fix the body missing it? So can you tell us what happens when we take something away? What do you do then to help the patient continue with what that function should have been?
Excellent question. So oftentimes that is actually a consideration when we make the decision about how much of a thyroid to take out. Just because there are thyroid nodules in both sides of the thyroid lobes do not mean that we absolutely have to take out the thyroid and have the patient take medication for the rest of their lives. If there is a good enough reason to, such as in a cancer case, and we absolutely need to eliminate all thyroid tissue, we'll do so. But that's one of the discussions that I will have with the patient if we have a choice as to how much thyroid to take out, because unfortunately we have thyroid hormone medication that will take up the missing portion of the thyroid and produce hormone or replace the hormone for the patient. So they're not going to necessarily miss the missing half of the thyroid, but it is a consideration. So those are some of the conversations that I tend to have with the patients when we decide together how much of a thyroid to take out.
Gotcha. What about things that we see in other parts of the world? Things like goiter.
Yes.
It's not so much of a problem here in America necessarily, but we still run into it every once in a while. So how do we manage those?
Yes. So we have a very robust immigrant population in greater Waterbury and central Connecticut area. So I do actually see quite a few goiters.
Okay.
And goiters are just enlarged thyroid.
Sure.
And by and large, they don't turn into cancer or anything, but what they do is they tend to continue to grow and cause symptoms. So if you happen to have a large thyroid that's causing compressive symptoms and making pills hard to swallow, or food hard to keep down, then maybe it is time to consider seeing someone and start talking about a surgical procedure for a goiter.
Yeah.
And sometimes people are surprised by the fact that they have a goiter that they did not know about, because they sometimes will come into the emergency department with shortness of breath, and one chest x-ray will lead to CAT scan, and then sometimes folks are surprised by this massive thyroid that is growing inside their chest. So those goiters will need to come out.
Sure.
And while it's not a pleasant surprise, patients oftentimes feel much better. They breathe better.
Great.
And we have excellent thoracic surgery team here that we can work together to tackle these issues.
All keeping the patients at the front.
Absolutely.
Keeping our systems connected. Beautiful. So let's talk about the future. I'd love to put on my future hat. What excites you about the future of endocrine surgery?
Yes. So endocrine surgery is all I do. So I think about that all the time.
Yes.
And I'm very in tune with the latest developments in endocrine surgery. And it is almost uncanny to me that endocrine surgery, we mostly deal with 3 or 4 glands, and is almost perfect the way that we do things, but we are still pushing the envelope and still coming up with different procedures. We're always aiming for the even smaller scars or no scar and no surgery, etc. So the latest development in the thyroid world is this needle treatment with what we call radiofrequency to ablate thyroid nodules without a surgery. So that's one of the exciting techniques that came about in the pipes, and I'm hoping to establish that program and offer it to patients around this area.
This is something that you're able to do.
Yes, absolutely.
Yeah. So, I mean, we're excited. I remember you giving a presentation on that a little while ago. So we're excited to start to develop that program where no surgery necessarily, at least from a scar perspective, but it's a needle that goes and actually ablates or sort of burns away to some degree that problem in the thyroid.
Right. So it will not be able to completely eliminate the thyroid nodule. However, it will shrink it to a point that the patient will achieve symptomatic improvement and will be able to avoid the surgery. So if the patient is not necessarily a greatest surgical candidate because of age or because of comorbidities, this will be an option for them. So it's exciting development in the endocrine surgery world.
That's an exciting piece for the future. Anything you want to add for patients to think about when it comes to thyroid health overall or adrenal health overall? Any small nugget of wisdom to help their general endocrine health moving forward?
Yes, most of our endocrine surgery patient population is women, and that's one of the reasons that I wanted to pursue endocrine surgery. And I, really enjoy the interaction with our female patients. But thyroid nodules and adrenal nodules, as well as high calcium issues, can exist in men also.
Sure.
So if you happen to see lumps and bumps in your neck, if you happen to have some of the symptoms of high calcium, as we mentioned, kidney stones and some of these non-specific tiredness, forgetfulness, etc., symptoms, do not hesitate to mention it to primary care physician who's taking care of you, so they can examine you and just take a look at some of the lab values. It may not even take a whole new set of workup, but just looking back at the trend and how the exam appears to clinician may be good enough to rule out or rule in some of the issues.
Yeah, yeah. It's funny. It's not one of those things that jumps out at you,
Yes.
but it creeps up along the way.
Absolutely.
So keeping in mind your symptoms can definitely be helpful. Well, again, I want to thank you very much for joining us today, and I want to thank everybody for joining us and listening in. Look forward to our next conversation. Have a great day.
Bye-bye.